dear friends, today I am going to give you one interesting case regarding the patient having last year admitted in our hospital with progressive dyspnea. And this is a story of Sri Ramlal, Premlal, working at Tata Nagar, presented to Central Hospital Garden Reach with complaint of fatigueness 6 months, dyspnea on exertion since 6 months. The history of presenting is progressive in nature. Dyspnea or NHOIA class 2 is a known hypertensive. History of palpitation on exertions occasionally. No frequent history of cough and cold. No history of weight loss or illness. No history of syncope. No history of diabetes, ischemic heart disease. Now, in past history, the patient denies history of RSD, ISD, tuberculosis, diabetes, any congenital heart disease. But he was taking already on hypertensive treatment on amlodipine 5 mg. He was a smoker, alcoholic, married, having 2 daughters, no history of any allergic history. Family members are normal, no history of consanguineous marriage in their family. So on general examination, he is a fully conscious, 5 feet 8 inch weight, 80 kg, build normal, anemia, sinuses, clubbing, JVP normal, sub absent, no lymphadenopathy, pulse was 75 minutes regular, high volume, no radiofemoral delay, and BP was 150 by 70, standing 146 by 70, hernial, all sides are normal. Regarding cardiovascular examination, normal shaped precordium with apex beat, outer side 6 interstitial space, 175 lateral to mid clavicular line, not palpable thrill, no parasternal dip. S1 S2 are normal. Early diastolic murmur grade 2 and systolic murmur grade 2 at the parasternal, second left intercostal space and base of the heart. No S3, no S4, no pericardiogram, no carotid fluid. Respiratory systems, bilateral symmetrical chest, central trachea, bilateral vesicular sound, no added sound. Nervous systems, higher functions are normals. Gastrointestinal system, all the abdominal no visceromegaly and all within normal limit. Locomotor system normal. So, in summary, the patient, 45-year male, non-hypertensive, as known case of hypertension, non-smoker, non-alcoholic, non-diabetic, presented with complaint of weakness and fatigue and dyspnea on continuous nature with all sorts of activity for 6 months, but no wheeze, no cough, no angina, exertion, syncope and other systems being present with it. On examination, apex beat, left chest interval space, lateral to left mid clavicular line with EDM, early diastolic murmur and ejection systolic murmur at parasternal, second left space and the base of heart. So with this clinical summary, there are very interesting cases, 45-year male, hypertension with this finding. So what are the possibilities here? If any basic possibilities are we dealing, since where there is ejection systolic murmur and diastolic murmur, that are we dealing with RSD with aortic stenosis regurgitation or some aortic valves disease like bicuspid aortic valves or some hypercardiomyopathy leading to some ejection systolic murmur or something else. So these are the possibilities in view of that. Now when patient was sent from Tata Nagar, we have investigated the case. There was a very surprise findings were got. Start with the blood findings. The hemoglobin normals, RFT, LFT, sugars normal, urine findings normal. There is a mild increase in 61 mmHg, sodium potassium normal, thyroid profile normal, lipid within normal limit. Now ECG, now faded, it within there was a normal with mild LVH pattern. This is the chest X-ray. You see there is a mild cardiomegaly is there. So there is a mild increase in cardiomegaly with ventricular enlargement. And if we did the echocardiography, there was a huge enlarged left ventricle. So LV was dilated. There was moderate aortic regurgitation. LV IDD was 7 cm by 4.6 cm. So easily dilated with aortic regurgitation. You can see this is the aorta, this is the left ventricle, this is the right ventricle, this is the left ventricle. So many of you, we have come to conclusion that there is a dilated aorta with regurgitation, moderate aortic regurgitation. Now, with other findings are within normal limit. There is a various view. You see, there is a aortic regurgitation is there. Aortic regurgitation. This is your continuous Doppler view. This is the left ventricular, and these all are the various findings. Now, when we try to know what is the cause of aortic regurgitation, whole thing is that, and when we did the thought of that young male with sudden onset dyspnea, with sudden deterioration of gradually aortic regurgitation. So then backlog we have gone for the history and suspected that are we dealing with something else what we are in past. And when we did the VDRL, it was a highly reactive. And TPHA test was done to confirm it because VDRL levels so big. It was again positive. So thing is that other serology, non-reactive, LVS non-reactive, SCV was non-reactive. Then we did the CSF examination to rule out neurosyphilis. And it was a clear sugar was itna, LDH itna, VDRL negative of this TPH. So CSF neuro was not involved, syphilis. But there was a change in this. Other investigation, we did all the ultrasound to rule out gamma at the various site of that, whether we are dealing with tertiary syphilis and various site. Most of the organs was not showing the various feature. There was some mass in the skin mass, one gummitous. We are taking the biopsy for the confirming that it is a gummitous. And then we start treatment with this. Skull was not showing any significant gummitous lesion. So our final diagnosis was aortic regurgitation in a background of hypertension with dilated aorta, involvement of aortic with TPHA and VDRL positive, and it is the case of syphilitic. What we have learned in the last 30-40 years before, it was quite common, but nowadays it is very rarely to be seen in a case of the syphilitic manifestation of this aortic regurgitation. So patient we have treated with penicillin and given them so that we can do this, and followed by screening of wife was planned. And when we retrospectively gone for the history, there was a significant history of the contact with commercial worker. So many things he committed later on, and it was absolutely full family screening was planned and ABR was planned for that. And so the patient was gradually improved with this, but the thing is that aortic regurgitation is the ultimately replacement is the ultimately planned, and the patient has gone for that. ABR क्या था? ABR